Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Still on diffuse lung diseases, today we're going to be talking about systemic idiopathic diseases that can affect the lungs. In this case, we're going to be talking about pulmonary sarcoidosis. So, sarcoidosis is an idiopathic systemic disorder of non-caseating granulomas that become coalescent to form nodules and masses throughout the body. So you can have sarcoidosis affecting the lungs since it's a systemic disease, and when it affects the lungs, it's called pulmonary sarcoidosis. This may progress to pulmonary fibrosis in the late stage, right? And we mentioned that one of the most common causes of pulmonary fibrosis is idiopathic pulmonary fibrosis. Now, unlike idiopathic pulmonary fibrosis, the fibrosis in pulmonary sarcoidosis have a mid and upper lung predominance, much similar to end-stage hypersensitivity pneumonitis. A historical staging system has been used for radiographic findings, not CT, in sarcoidosis. However, patients do not necessarily progress through the stages, so from stage 0 to stage 4. This staging is called historic because it was in the 1960s that it was first developed. It was based on plain radiographs, and also it doesn't necessarily predict disease progression, such that a patient who has stage 1 disease may even be having more clinical symptoms than someone who has stage 3 or stage 4 disease. So in the advent of high resolution CT and PET scan, this staging has been rendered obsolete. But just for historical purposes, let's just know that stage 0 is someone who has sarcoidosis, but on radiograph you don't see any pulmonary evidence. Stage 1, there is hilar lymphadenopathy only. Stage 2, you have hilar lymphadenopathy now with some lung changes. Stage 3, the adenopathy goes away, but the lung changes remain. And in stage 4, end-stage fibrosis. While the most common radiographic finding in sarcoidosis is symmetric adenopathy, sarcoid does not always present with lymphadenopathy, and it can be present without lymph node enlargement. Lymph nodes, if they are present, may contain stippled or eggshell calcification in up to 50%. Now, in these images, the very first one, the plain radiograph, is a case of stage 1 sarcoidosis, and it shows symmetric adenopathy, demonstrating what we call the 1, 2, 3 sign. We have the right paratracheal lymph node here, numbered 1. Then we have the right hilar adenopathy, numbered 2. And then the left hilar adenopathy, number 3. That gives us the 1, 2, 3 sign, or the Pon-Bruker's sign. This axial CT in a different patient shows peripherally calcified eggshell lymph nodes in the mediastinum. The most common CT finding in sarcoidosis, in addition to the adenopathy that we've spoken about, is upper lobe predominant perilymphatic nodules. These nodules can be of variable sizes, and these represent sarcoid granulomas. When we say perilymphatic nodules, as we have discussed earlier, when we're talking about approach to micro nodules, perilymphatic nodules are found along the course of the pulmonary lymphatics, which are peribronchovascular, subpleural, and also within the interlobular septa. Septal thickening may occur, but it's uncommon in sarcoid, apart from the septal nodules that we would see. Perilymphatic nodules may coalesce into a mass up to several centimeters in diameter, and this gives us what we call the galaxy sign, and that's where you have this mass with small nodules seen peripheral to it. The nodules may occasionally be miliary. Diffuse micronodules may also simulate ground glass. If the nodules are diffusely distributed, it may look like it's ground glass. When you have fibrotic sarcoid, it will affect the upper lobes predominantly and can produce what we call progressive massive fibrosis, just like what we saw when we're discussing the pneumoconiosis. When the bronchi are involved, because of airway obstruction, would have mosaic perfusion due to air trapping. So in these images, this axial CT in a patient with sarcoidosis shows tiny peribronchovascular and fissural nodules in the bilateral upper lobes. You can see some in the peribronchovascular distribution up here, and we can see some in the fissural distribution down here. And this coronal CT demonstrates upper lobe predominant progressive massive fibrosis of sarcoid with the galaxy sign. You can see some tiny nodules satelliting this massive area of fibrosis. Now for a bonus, we'll talk about pulmonary alveolar proteinosis. Pulmonary alveolar proteinosis is an idiopathic disease, and it causes filling of the alveoli with a proteinaceous lipid-rich material, hence the name pulmonary alveolar proteinosis. On chest radiography, pulmonary alveolar proteinosis may resemble pulmonary edema with perihilar opacification. However, unlike pulmonary edema, you would see that the heart is normal. You would also see that pleural effusions are not typically seen. That helps you differentiate between cardiogenic pulmonary edema and pulmonary alveolar proteinosis. The CT hallmark of pulmonary alveolar proteinosis is the crazy paving pattern of smooth interlobular septal thickening in areas of patchy or geometric ground glass. So a combination of smooth interlobular septal thickening and ground glass attenuation. Initially, crazy paving pattern was described for pulmonary alveolar proteinosis, but it has been found that it's not specific to pulmonary alveolar proteinosis, as there are other conditions that can lead to crazy paving pattern. We discussed a number of these in one of our earlier discussions on patterns of lung disease. Now, patients with pulmonary alveolar proteinosis are susceptible to superimposed infection, classically with nocardia, and this typically presents as a consolidation superimposed over the crazy paving appearance of the lungs. Treatment of pulmonary alveolar proteinosis is whole lung bronchoalveolar lavage. So in this image, it's an axial CT which shows bilateral crazy paving predominantly in the right lung, and we also see a dense consolidative opacity in the left upper lobe, representing superimposed nocardia pneumonia. All right, so that brings us to the end of this discussion. The next thing we'll talk about is cystic lung disease. Thank you very much for your attention, and give this a like, comment, share to someone who might need this, and I'll see you in the next one.